So my Doe and I are debating this topic. And my position is that allergy is in fact a significant etiologic factor in the development of chronic rhinosinusitis. I'm Stuart Gann. For those that don't know me, I'm a third year here. So as an overview of what I hope to present, to begin with, as I prepared for this, it became clear that the most commonly and agreed upon belief is that the etiology of chronic rhinosinusitis is multifactorial and still being elucidated, especially when it comes to mechanisms. In the context of that, however, there is strong pathophysiologic rationale for allergy as an etiologic factor in the development and essentially sustainability of chronic inflammation and chronic rhinosinusitis, as I'll show. And there's a growing body of evidence supporting multiple mechanisms relating to allergy, relating to the two, a lot of which have become more apparent as we've gotten more sophisticated in our immunologic capability, essentially. Thirdly, there's compelling epidemiologic evidence linking the two. And there's been demonstrated to be an association between allergy and the severity of disease in rhinosinusitis. And finally, there are known treatment associations between allergy and rhinosinusitis. So to begin with, as I mentioned, most people agree that etiology is multifactorial. You commonly see this breakdown in many textbooks and papers. The three major contributors are considered environmental, anatomic, and then systemic disease, which is a big catch-all. Of course, allergy and immune-related factors can be considered either environmental, well, actually both environmental and systemic. But in terms of the final common pathway, it's generally agreed that some form of inflammation, and I would argue including allergic inflammation, contributes to the final common pathway of this disease. So the basic physiologic rationale that has traditionally been talked about is that, first of all, the airway mucosa is in continuity with the sinus mucosa in most cases. Because of this, it has been postulated that in terms of allergy, an allergic response elicits essentially edema in the tissue, which causes obstruction of the ostia at the OMC, reduced ventilation, which leads to negative pressure and reduced oxygen tension. This is thought to lead to impaired ciliary function, and then essentially the cycle continues as mucus builds up, and it creates a favorable environment for, among possibly many other things, bacterial colonization, but possibly many mechanisms. In addition, there's this idea of priming of the mucosa, whereby repeated exposure to allergen reduces the response thresholds to other allergens, and this causes a cycle of increasing edema, and then, as I mentioned, priming of secondary bacterial infection. Ultimately, it's thought that mucociliary dysfunction is essentially what leads to the chronic inflammation and the symptoms. So, in terms of physiologic evidence, from an immunohistopathologic perspective, allergy is an IgE-mediated disease, type 1 reaction at the mucosal surface, beginning at the mucosal surface. Patients with allergic sensitivities and demonstrated elevations in IgE have been shown to have more extensive sinus disease than non-allergic patients. These patients are with documented inhalant allergies are also more likely. Basically, CRS is more prevalent in those patients. And patients with inhalant allergies are more likely to have surgery. This is from Dr. Huang's study. Number two, in terms of cellular response, it's been shown as in many other domains of allergy that eosinophilia is a prominent feature. This is obviously clearly implicated in allergic inflammation in general. Specific to the sinuses, it has been shown in a couple of studies to be the predominant inflammatory cell type in the mucosa and sinus fluids of chronic rhinosinusitis patients. A higher number of, these are found in higher numbers in the sinuses of allergic patients who also have chronic rhinosinusitis. And there's a high prevalence of eosinophilic inflammation in mucosa in patients with especially refractive disease. Another significant cellular mediator would be the mast cells, which, as a review, antigen cross-linking to adjacent IgE causes release of mediators from the mast cells. This is thought to be a Th2 mediated mucosal inflammation. The allergic response in, the inflammatory response in allergic rhinitis is thought to be largely Th2 mediated and can cause reactive hyperplasia of mast cells, as demonstrated in assays from chronic sinusitis patients who also have allergic rhinitis. This has also been postulated to possibly trigger a more sustained inflammatory response to infectious stimuli by causing essentially changes to the mast cells involved in the inflammation in patients with Th2-mediated milieu thought to be associated with allergy. In terms of immunologically active molecules, two that are often studied and mentioned are IL-4 and IL-5. These are part of, as you can see in this very complicated diagram from medical school, part of the inflammatory response mediated by Th2 cells. IL-4 is thought to essentially, most importantly here, affect eosinophil recruitment, whereas IL-5 would facilitate eosinophil growth and survival. Chronic sinusitis patients, in these patients, the immunologic response has been shown to be related to the Th2 cytokines, and specifically in allergic patients, where there are higher levels of IL-5 noted in the sinuses, correlated with increasing tissue eosinophilia, also in allergic patients, and specifically in this case with polyps. The increased expression of IL-4 and IL-5 receptors in allergic patients with chronic disease has also been demonstrated. So there are also, beyond directly, mechanisms associated with direct mucosal allergic response, there has been some work demonstrating more systemic and alternative mechanisms which may affect the sinuses more broadly in response to allergic stimulation. One such proposed mechanism is often called the neuroreflex. Basically, it's allergic inflammation in the nasal cavity that causes sinus inflammation, even when there's no direct contact between the allergen and the sinus mucosa, as is often the case when patients have edema and closed osteo. There was several studies done to this effect where they instilled antigen, in this case into the lungs, and noted increased eosinophils, IL-5, and mast cell degranulation in sinus tissues. Another similar study, they essentially did the same thing in one nasal cavity and lavaged the bilateral maxillary sinuses and noted increased eosinophils on both sides of the sinuses. So the proposed mechanism is that this may be mediated by a neurologic reflex stimulated by allergy in the nose with effects in the sinuses. There's traditionally the original sort of link between allergy and chronic rhinosinusitis was observed epidemiologically. And there's a lot of studies on this, and most of them are retrospective and sort of retrospective case studies. There's a higher prevalence of skin test positivity in rhinosinusitis patients than in healthy controls who also have, in other words, they took a cohort of 224 patients who had acute maxillary sinusitis and compared them with 103 controls, and 45% of the sinus patients had positive skin tests versus 33% of the non-sinus patients. The prevalence of allergy in the general population is quoted anywhere from 15 actually to 30% in what I read. One study, actually multiple studies, have shown up to 80% of patients who underwent, who have elevated IgE levels are positive for at least one antigen. This particular study, it was from a cohort of patients who had had sinus surgery. It's also been demonstrated that the severity of disease may correlate with the presence of allergy. As assessed by skin testing, it's been shown to be significantly associated with decreased quality of life in questionnaires. And allergic patients with sinusitis often have more severe disease demonstrated on CT than non-allergic patients. This is actually borne out in several studies. It's questionable whether or not those patients have, well, it's known that they don't necessarily have worse symptoms, but they do have worse demonstrable disease on CT scan. So again, the extent of this disease on CT and the presence of eosinophils in sinus tissues has also been associated with elevated IgE on allergy testing. So in terms of treatment associations, it's generally, I feel, taught and believed that rhinosinusitis involves an interaction between the structural and physiologic factors, hence the need for treatment of both, essentially both medical and possibly surgical treatment in these patients. And it's been demonstrated, actually, by several studies that failure to address allergy when it's obviously apparent in these patients will result in refractory cases, especially in the case of surgery, which stands to reason. If patients obviously have allergic components and it's thought to contribute to their rhinosinusitis, neglecting to treat it obviously will result in poor outcomes. This is from a large review from the University of North Carolina. There's also been shown a decrease in the occurrence of acute and recurrent infections following initiation of immunotherapy in these patients. So just as a quick overview, again, reviewed the fact that etiology is likely multifactorial, but there are strong and growing body of evidence that links the spectrum of chronic sinusitis with allergy on a physiologic basis. There is compelling epidemiologic evidence to that effect, and that we observe it clinically in the association between severity of the disease and allergy, as well as implications for our treatment. So, a lot of references, which you can glance at. Do we take comments now, or?
Well, no, let Doe say what he's going to say.
Okay.
So yeah, I'm gonna talk about on my side. So my position is the. So my position is the. My name is Dorian. I'm the PGY4. And my position about today's debate is that allergy is not a significant etiology factor in the development of chronic rhinosinusitis with and without nasal polyposis. So I don't have any financial disclosures. And first of all, I'm going to talk about definition. What's the definition of allergies? And people sometimes get confused. And I'm also going to talk about, we're talking about chronic rhinosinusitis. Stu just showed some data about acute maxillary sinusitis, but we're not talking about acute sinusitis, we're talking about chronic rhinosinusitis. And secondly, I just want to talk about what's the prevalence of allergy in chronic rhinosinusitis based on the literature, And then I go over what about the severity of chronic rhinosinusitis in patients with and without allergies. And I'm gonna also touch a little about IgE factors and is there any evidence? Or what about allergic fungus sinusitis? Is there any other evidence for that? And then based on that, I just want to make my own hypothesis and then my small research about the DUOX, and then I make a conclusion. So definition first is that hypersensitivity. What's hypersensitivity? Is that it's reproducible harmful symptoms and signs which was initiated by exposure to a dose which is tolerable or which is tolerated by a normal person. So this is what we call hypersensitivity. And definition of atopy is kind of more of a tendency. So atopy could include allergy, allergic rhinitis, but it's more of a tendency to become sensitized and actually produce IgE antibodies to the certain antigens. And sensitization is that positive specific IgE level, however, we don't have the symptom. If the person doesn't have symptoms, so we call the sensitizations. The definition of the allergy is that clinical history definitely has to have clinical history, and also have a specific IgE test by laboratory, which could be the RAS test or could be the skin testing. So these are the definition of allergies. But however, the study of allergic chronic rhinosinusitis is very difficult. The reason is that there are a lot of symptoms overlaps. Patients have runny nose and also at the same time allergies, but it's really difficult to tell which patient really has an allergy symptoms or like sinusitis. So sometimes this definition of the, to put into the clinical study of the allergic chronic sinusitis is sometimes very challenging. So here in the chronic rhinosinusitis, we like to involve, based on my review, to involve the chronic sinusitis without nasal polyposis, and also chronic rhinosinusitis with nasal polyposis. And with nasal polyposis, we can divide into two groups. With the nasal polyposis, the mucus could be eosinophilic absent, and also eosinophilic present. In patients with the eosinophilic mucus present group, there are like 4 categories, based on patient has fungal allergy, with and without fungal allergy, also with and without fungus in the mucus. So based on these categories are included in the chronic rhinosinusitis. And this category was been demonstrated by initially demonstrated by Dr. P.J. Warmer in Australia, and that he actually did some studies about is there any clinical difference or any other IgE level difference based on these categorical groups. And Stu already talked about the common etiology of chronic rhinosinusitis, and today focus about whether allergy is really related to chronic rhinosinusitis. I just want to pull up this article, which is done in 2008, published in this journal, and they actually studied about 115 patients, and they want to study whether the allergy, allergic or non-allergic rhinosinusitis actually really predisposed to having chronic rhinosinusitis. It's more cross-sectional studies, and what they've been shown is that asthma and chronic rhinosinusitis were not significantly different in patients with allergic and non-allergic patient. And when you do CT scans of their sinuses appears to be actually much more, scores are much more higher, which means the CT finds it worse in patients without allergies compared to with allergy. But their p-values are kind of at the borderline. So their conclusion of this study shows that the allergic and non-allergic rhinitis may not differ significantly in these two in developing this chronic rhinosinusitis. They said the role of the atopy does not seem to predominate the pathogenesis of chronic rhinosinusitis. So allergy-specific treatment may not be effective in patients with chronic rhinosinusitis. And the other study shows that also very similar findings, that there's no significant increase of prevalence of allergy and chronic rhinosinusitis compared to general populations. And also there are about like 0.5 to 4.5% of allergic rhinitis in patients actually have nasal polyposis, which is very similar to the general populations. And also shows that the prevalence of polyp in the allergic rhinitis is very variable, depending on all these studies. And the next paper I just wanted to talk about is about what about the severity of chronic sinusitis. A patient with severe sinusitis is maybe more with an atopy, or maybe patient has more severe allergies. So this is studies done by the University of in the Northwestern University by Dr. Kern's group, and they cross-sectional study about 106 patients, and they show that first of all, they launched McKay score, which is CT scans are very similar between patients with atopy and non-atopy patients, and there's association between the between the systemic atopic status and chronic rhinosinusitis severity. There's like a weak correlation between these two findings. So their conclusion is that this is a very huge group of the Northwestern group is a very huge group in American Rhino Society that they study about the allergies. Their conclusion in 2009 paper shows that chronic rhinosinusitis is an inflammatory disorder, but that actually occurs independently of the systemic IgE-mediated pathways. So that means that allergy may not be really related to the development of chronic rhinosinusitis. And so the other study shows that this is a study done by Dr. Tim Smith, who's in the working group. He studied about like 106 patients, and they have 4 studies, which shows that allergy does not have an effect in their objective measures. And all patients have very similar CT scores, whether patients have allergy or non-allergies. And their endoscopic scores, the preoperative, postoperative periods are there's no difference. And also the degree of improvement after surgery, they didn't see any difference in terms of the degree of improvement after the surgeries. And Dr. P.J. Warmer's studies in Australia shows that there's a high prevalence of atopy patients with CRS without nasal polyposis and compare the patients with a CRS with nasal polyposis. So Dr. P.J. Warmer's study showed there's no significant influence of atopy on symptom severity, and also extent of the sign of disease on CT scans, and also the likelihood of undergoing revision surgery comparing to the patient with non-allergic chronic rhinosinusitis. But clinically, there is no much of correlation between the severity of chronic rhinosinusitis and allergies based on the major studies, which is done by Tim Smith and also Dr. P.J. Warmer. So what about IgE? There's any evidence that IgE is actually more severe in patients, like higher in patients with a chronic rhinosinusitis. So when we study about allergic fungal sinusitis and also related allergic rhinitis with fungal allergies, there's no significant difference in terms of their total number of IgE levels and fungal-specific IgE levels between all these groups. And also the certain groups of chronic rhinosinusitis with the eosinophilic mucus and nasal polyp did not have a IgE-mediated allergy on skin testing, or also they don't have any elevated serum-specific IgE levels on these allergens. So, and also Dr. Deviani Latry, she was one of the Dr. Wang's previous fellows. She wrote a paper in 2006 that when they followed these patients about a year after they actually had the sinusitis and also the immunotherapy, there's no significant change in the total IgE level up to 1 year after the sinus surgeries. So, and also the fungal immunotherapy, especially immunotherapy in patients with allergic fungal sinusitis, they failed to show a significant impact with respect to the number of operations and sinonasal mucosal staging and quality of life scores, all these patients. So this is pretty controversial. So pathogenesis, the evidence of IgE-mediated hypersensitivity, was very controversial based on the studies. However, the major study shows that there's not much correlation between the chronic rhinosinusitis and IgE levels and allergies. So whether we don't know then clear whether really the allergy worsens sinonasal inflammations and clinical outcomes. So is it still the allergies? Is that causing chronic rhinosinusitis? So I want to go back to all these previous slides, and I think the bottom line was that this is also the studies. This is also the slide kind of shown in the previous Dr. Wang's course in Sonoma. That I think that everything goes into the one kind of like category that's more inflammatory load hypothesis. So all these allergies, fungals may be related to some degrees, but they're not obviously cause chronic rhinosinusitis. I think the major factor is the inflammatory load hypothesis. There's more inflammation, inflammatory load in the tissues, then they may develop some chronic rhinosinusitis. Then how can we detect the inflammation level in each tissues? There might be, we probably have to get a better markers or study about the levels of inflammation. So one of the research that I'm doing is about the duoxidase. Duoxidase is one of the NADPH oxidase located in the airway epithelial cells, just like the neutrophils. And DUOX is actually only being expressed, DUOX2 is only expressed only in infection and inflammations. So what it causes is that DUOX, NADPH oxidase located in the apical portion of epithelial cells, and actually that produces the proton into the protons are produced into the air surface liquid through proton channels, and by the DUOX produce these oxygen radicals, and they produce hydrogen peroxide in the air surface liquid. So the air surface liquid actually sometimes could be harmful, but however, when there's more inflammations and actually the hydrogen peroxide levels are more increased in the air surface liquid, and these hydrogen peroxides have been used to produce hypocyanide, which could eventually may kill all these bugs and also possibly may injure its own tissues by too much inflammations. So these are kind of more of my hypothesis. And then my recent study showed that DUOX2 levels are significantly increased patients with and without nasal polyposis compared to normal controls. And also hydrogen peroxide levels are pretty much increased patient with normal compared to normal. The chronic CRS with and without polyposis shows increased level of hydrogen peroxide. And when we look at the correlation curve, there's more DUOX production, there's more increase of hydrogen peroxide level in the airway secretions. So, and then these slopes show there are significant correlations between these two axes. So my conclusion is that there's no, there's the conclusion evidence the pathogenetic pathway, the allergic cause mucosal swelling and cause sinus drainage problem with the compromised drainage problems, and also the ciliary dysmotility may cause bacterial growth. All these pathogenic pathway appears to be very, the evidence of these pathogenic pathway appears to be very lacking. And there's also the insufficient evidence to that IgE-mediated allergy is actually causing the sinonasal inflammation of chronic rhinosinusitis. So the allergy may not play an important role in the pathogenic chronic rhinosinusitis, and so there may be more accumulating evidence of the involvement of local microorganisms, local environment in the airway surface levels rather than in a generalized allergy or in the blood levels. So the modulation of the mucosal immune response may be related to the pathogenesis of chronic rhinosinusitis. Thank you.
Did you come across the role of the complement cascade in development of sinusitis and polyps? Do they still talk about the complement cascade?
No, I didn't. I didn't go over that part. Yeah.
Do you know what that is?
Yeah.
Okay.
Yeah.
And that hasn't been implicated. Where's Peter?
China.
Okay. Anybody want to help me on this one? That's the reason that what's in that pill that you take it for allergies once at night. That's the purpose. Singular, right. That's supposed to be a role in modulating sinusitis.
Yeah.
It's not initially, okay.
Joe, can you go back to the slide that showed the slopes? Yeah. To my eyes, it looks like those dots are about the same between the two groups. So that actually came out to be statistically significant.
No, this is separate. Like the black is the DUOX2, and then so this is the correlation between the hydrogen peroxide secretion and levels of DUOX expression in the airway epithelial cells. And so this is the black bar is this is done by statistics. So this red and blacks are totally different groups. Red is a study about DUOX1. The black is a study about DUOX2. So there's like lower levels of DUOX productions, and there's a low levels hydrogen peroxide secretions. If there's more levels of the DUOX production, there's an increased level of hydrogen peroxide levels. So Yeah, I mean, this is done by, I know the sample size definitely is so much lower than, I think the sample size probably, I think it's about 7 or 8, but it could be probably, yeah, power could be, we probably could increase it.
How do we reconcile these two sets of data? It almost reminds me of statistics like a lamppost for a drunk. It's good to lean on, but it doesn't always provide illumination. You clearly have both sets of data that show your points of view. Intuitively and from personal experience, you think that allergy, at least in some cases, would have a role to play, and in others it clearly doesn't. How do you reconcile your points of view?
Well, so in reading to this, it is clear that there is no good, prospectively demonstrated association. I mean, I'm arguing against myself now.
Yeah,
Even mechanism. Yeah, that's right for truth. But there's no, essentially the data is lacking on my end. It really is. I mean, so there's a lot of epidemiologic data, and there are good rational, there seem to be a lot of good rational ideas about how these things might be related, but there are no, I don't think there's any hard, what we would call hard data that actually show it. I mean, I know what you mean. Anecdotally, we all kind of are taught and think that way about this. We treat allergy definitely when we consider a patient to be atopic and have sinusitis, and at least I feel like we're taught that not doing so is doing a disservice to your patient, which it probably is, but if they're not associated, then why would it matter? Why would not treating allergy, affect your treatment of chronic rhinosinusitis if they weren't related?
There's a very large body of evidence that's coming out now that you can't diagnose someone's allergy based on the systemic levels of IgE and immunoglobulins, because systemically they may not have any elevation, but at a local level they've got a higher upregulation of their local IgE and local immunoglobulins. So it could be that our assessment of allergy and our diagnosis of allergy is crude and reliant on techniques of days gone by, and as we develop more sensitive techniques to diagnose local allergy, we may find the links are more substantial and I just did some research last year which showed local B cell production, important producing immunoglobulins, was way off upregulated in patients with polyps compared to any other group. And that's consistent with literature that patients with polyps have local IgE, local IgG elevations, but have the same systemic levels of immunoglobulins as patients without polyps. So I think that's where the discrepancy may lie. It may lie in our diagnosis and our detection.
Interesting. Thank you.
So I have an observation in terms of the weight of the evidence, which may or may not be of probative scientific value. I would point out that the Stanford Sinus Center employs 3 part-time allergists and does ask for desensitization. And if it is not related to the surgical aspects of nasal disease, why in the heck are you doing it?
We all talk about chronic rhinosinusitis, but we never talk about like Sampson triad or cystic fibrosis, other type of nasal polyposis. So we only talk about chronic rhinosinusitis. That's the definition. So we didn't go for that. The other part of the so we do aspirin desensitization more patients Sampson triad. This is not the part that we're discussing.
Well, but even if it wasn't related, it's sort of like a comorbid condition in the same area, so it makes sense to treat it. So it doesn't really matter, I think.
Okay, let's move on. We have a whole nother debate to do, so let's go ahead and move on. Joe,
Okay.
maybe you want to do ashes first?
Yes.
So, you going to explain it?
Oh no, go ahead, please. Okay, I can explain. That was the wrong answer. So Ash and I are going to participate in this debate with regard to whether or not T-mastoid for the treatment of cholesteatoma should be staged. And Ash unfortunately could not be present today, although he prepared his presentation, and I'm told that once I hit play on this presentation, it actually has audio. So
So just to be clear for the rest of the residents, Ash was told about this debate several months ago, and however, he forgot to, it did not register. And so he is on vacation this week, and he realized last week that he had the debate this week. And so it was too late to switch with anyone, and so this is a not so great, but better than nothing, solution to the problem. We're using a little technology here, so. I don't want anybody else to think this is a great thing to do in the future. Okay?
All right, so whatever Ash's point of view is, and whoever's arguing the other side, I will argue Rash's point of view.
Excellent.
I have no idea which way it is.
I'm going to say ahead of time that that's not fair.
All right, Nick will be on the other side.
Okay. I apologize ahead of time for any technical difficulties.
Hi, this is Arnash Shahanjian, and I'm getting in touch with you from Puerto Rico. My argument will be for staging tympanomastoidectomies, and I don't have any disclosures to present. When we talk about formation of acquired cholesteatoma, 4 different theories are presented, and there's evidence for all these 4 different theories, and I won't go into details of each of them. Basically, there's the invagination theory, basal cell hyperplasia theory, epithelial invasion theory, and metaplasia theory, all of which basically, as depicted on the right, show different mechanisms for formation of cholesteatoma in the middle ear, and have been proven by different bodies of evidence, and in fact, all of them may be at play in different cases. Why do we care about cholesteatoma? Well, cholesteatoma basically leads to formation of biofilm bacteria, which causes production of a lot of inflammatory cytokines such as TNF, IL-1, and IL-6. This leads to activation of production of rank ligand by resting osteoblasts, as well as bone marrow-derived monocytes, which then differentiate into osteoclasts, which result in resorption of the bone. This can be the bony ossicles, or the tegmen, or the bone of the aortic capsule. So typically, cholesteatoma causes a lot of different problems in the middle ear, as far including problems with hearing, problems with draining ear, or fistulas, and so on, and even hearing loss that can be sensorineural as it erodes into the aortic capsule. And surgical management is usually advised. Simple mastoidectomy is the most common way we deal with this. This is a pretty straightforward procedure where we drill down the mastoid, and depending on the extent of the disease, different procedures can be used. The canal wall down tympanomastoidectomy is broken down into modified radical mastoidectomy and radical mastoidectomy. These are relatively invasive procedures that were traditionally used for dealing with this problem. The difference between radical and modified radical being that the modified radical doesn't do anything in the middle ear. You remove the posterior and the superior canal. This is also referred to as the Bondi procedure. And the radical mastoidectomy, you completely exteriorize the middle ear, and this is really for selected difficult to eradicate cases. Obviously, with this procedure, you're left with a mastoid bowl that is going to require lifetime cleaning. The canal wall up tympanomastoidectomy is somewhat of a newer procedure, devised about 30-40 years ago, and it was meant to reduce the post-operative morbidity in these cases and issues with the mastoid bowl. It's basically leaving the canal wall, the posterior canal wall, intact, which again limits the surgical view of the middle ear, and it allows the cholesteatoma to grow in some nooks and crannies. These cases are usually require a second stage procedure, given the high recurrence rate, to actually look for residual or recurrent cholesteatoma and then perform any reconstructive surgery at this point. So these depict two different images of an adicolocystoma. On the left, you'll see an adicolocystoma that's extending posteriorly into the mastoid space and coming down inferiorly and posteriorly into the facial recess and sinus tympani. And that is the image on its side showing places that the cholesteatoma likes to hide in the middle ear, sinus tympani, and the facial recess, so very close to the facial nerve. So why do we want to stage cholesteatoma? So there's a great body of evidence that shows that residual or recurrent cholesteatoma are a big problem with all types of surgeries, particularly in canal wall down. Some of the first series that came out, large series that came out, is from Sam Kinney's group in 1988. He had 104 patients that underwent canal wall up mastoidectomy, and he had a median 9.2-year follow-up. And he reported a 25% recurrence rate overall and an alarmingly high 39% recurrence rate in children. Shelton and his colleagues in 1990 reported 400 ears with various techniques using canal wall up or canal wall down, or even transcanal removal of cholesteatoma, and they reported about a 1/3 residual or recurrent cholesteatoma, and most of their cholesteatomas occurred in the mastoid and middle ear, although they don't really specifically talk about the subsites. Recurrent cholesteatoma, again, Hanginomori in 2012 and his colleagues reported 85 ears that underwent canal wall up mastoidectomy. And this study, they actually planned the second look in 1 year, and 21% of their patients had recurrent or persistent disease. And they have a very nice diagram that shows the distribution of these cholesteatomas. Most of these recurred in the epitympanum, sinus tympani regions. And they attributed the recurrence rate to the inadequate visualization and drilling. There are some studies that came out very early on that actually supported, again, the same sort of numbers, 20 to 40% recurrence rate. And some of the early studies actually also supported the fact that it seemed that children had a higher recurrence rate. And this was particularly the case with children that underwent canal wall down technique. Obviously, these children were the kids that had the higher disease burden and had more aggressive disease. And it's been argued that perhaps the disease in children, which is slightly different probably from aquatic cholesteatoma, and it's congenital in nature, it can be actually slightly more aggressive, leading to the fact that they have increased rates of recurrence. Dodson et al. Had a meta-analysis actually of multiple studies looking at papers that came out between 85 and 95. They looked at 1,500 total cases. Canal wall down failures were 22%. Canal wall up cases were 42%. And they, again, favored a more aggressive disease in children, which was supported by higher rates of ossicular erosion and disease that was more likely to recur. Favoring coming back in these kids and taking another look before we clear their ears, basically. So what about hearing outcomes? So the data on hearing outcomes actually is rather mixed, and it's really hard to get a good study that tells you staging, whether staging or not staging is helpful or not. There's a nice study that came out by Kim and colleagues that looked at basically doing a one-stage versus two-stage tympanomastoidectomy with OCR. If you look at group one, group one is the group that underwent single-stage surgery, and group two is the group that underwent two-stage surgery. When they completed their analysis, looking at the two groups, they couldn't find any significant hearing outcome changes between the two groups, and they did a subgroup analysis in this retrospective study and found that the group that underwent a canal wall down with total ossicular reconstruction prosthesis, in this group, it seemed like there was a trend towards better hearing outcomes when the stage procedure was undertaken. This was really the only part of the study that reached significance. I should mention that their outcome measure was looking at an ABG gap of less than 20 or less than 30. Also, they compared the mean postoperative ABG. They didn't really look at the percentage ABG improvement, which I think would also be significant to look at. And the other group and that they also analyzed was a group right underneath the group that is highlighted in the rectangle. It's the group that underwent canal wall up with TORP, and this group actually had a trend towards better hearing outcome when a single stage procedure was used. But then again, there was, I think, too much variance, and they couldn't reach significance. So I think the jury's still out on whether better hearing outcomes can be reached by one method or the other. So let's talk about why we don't want to do a single stage. I think there's a great body of evidence out there that shows that you can miss cholesteatoma in hard to see places such as the cog, sinus tympani, adduct, and so on. I think if you do go ahead in these cases and do an OCR, you're probably going to have a high likelihood of having to come back and remove infected hardware, let the ear cool down, and then do the OCR in a third procedure, which is undesirable. As I'm sure Joe will talk about, there is a lot of excitement around non-echoplanar and DWI MRIs for following these patients after doing tympanomastoidectomy. I think the caveat is that this is still a relatively new procedure. Large population studies are still needed to kind of validate this measure. There's a nice study that actually came out of our group here at Stanford with Dr. Blevins and Peter Lee, looking at sensitivity and specificity, and I think MRI is a good viable choice, but I think it's probably not going to be feasible everywhere because you're not going to have the expert radiologist, and I think the other problem is that it can tend to miss smaller cholesteatomas. And I think the other thing that is not in favor of MRI, I think in the age of rising healthcare costs, we have to think about how much an MRI costs, and with an average cost of about $4,000 per series, and some of the patients requiring multiple MRIs to kind of follow and see if there's something that's actually growing in size. I think you can argue for doing a minimally invasive second stage procedure to cut the costs and the length of us following the patient. The other thing that I would mention about MRI, it hasn't really been validated in younger children, and I think it comes with its own difficulties of having to put the child under anesthesia, which is basically exposing them to the risks of anesthesia, which is a really major risk with this type of operation when you're talking about a second look operation. So I would be highly in favor of doing second stage procedure in children, or when the technology or the radiology department is not reliable. So when would I stage? I would stage when you're planning to do an ECR and there is a significant disease burden, because these cases are the cases that tend to recur, and they tend to recur because the invasive nature of the cholesteatoma and because there were places that it can hide. So I think it'd be reasonable to wait and perform a second stage in these cases. If you have cholesteatoma that is hiding in the sinus tympani or around the cog or the epitympanum, these are good cases to just be patient and wait until a second stage to perform an OCR. I think I would stage when you're performing surgery in child, because the cholesteatoma in kids tends to be a lot more invasive, a lot more aggressive, with a lot more chance for vesicular erosion. I think it's more difficult to follow them with MRI, so I think you want to come back maybe sooner rather than later to look and see if you've cleared everything, and then do the OCR at this point. Obviously, if you have a very limited tympanic membrane cholesteatoma, or something that is just easily visible in the middle ear and can be scooped out without any extension into the ossicles or the sinus tympani artificial recess or the attic, I would say you can opt for single stage in those cases, but I think in most cases I would be more conservative with a second stage approach. And obviously the consideration is whether your patient is healthy enough to undergo a second operation. I'd be more inclined to do everything I can in a 70-year-old with coronary artery disease, as opposed to a 20-year-old who's healthy enough to undergo a second operation, as well as going to have to deal with his ear for a long time. So at this point, I'm going to end the presentation and open it up for questions. Thank you all for your attention.
Ash
Telemedicine at its best.
He is available for questions if people have them. He can call in.
Just a definition, I think nothing to do with the pros and cons. A modified radical mastoidectomy means not that the middle ear isn't operated, but in fact that the middle ear is, right? That you repair the drum or ossicles is what makes it modified. There's a variant called the Bondi modified, where you don't go in the middle ear. In general, the whole point of a radical rips everything out. A modified, you do something with the middle ear, just so clear. And residual recurrence got kind of mixed up there a bit, where there's some headers that said residual when it meant recurrent and vice versa. Eduardo, do you want to see around?
He's right behind you.
Yeah, could you just explain briefly while I get started the difference between residual and recurrence?
So residual cholesteatoma is one where you actually leave a little bit of cholesteatoma, intentionally or unintentionally, depending on the situation. And recurrent is basically a whole other area of recurrent, a whole new recurrent cholesteatoma. Does that make sense?
Okay. All right. So go ahead and begin. So again, the topic that we've been assigned, two-stage tympanomastoidectomy, is indicated for treating the majority of cholesteatomas, and I'm arguing that the above statement is false. So Ash did a good job, so I'll be quick with this, but a basic discussion of surgical management of cholesteatomas in general. The goals of the surgery is to create a safe and dry ear by removing or exteriorizing all cholesteatoma, as well as preserving hearing function. So the majority of surgeries done for cholesteatoma involve a tympanomastoidectomy. Small majority can be approached via tympanoplasty alone. We'll a small pearl behind the eardrum, for example. But in general, you're either going to have a canal wall down or a canal wall up, tympanomastoidectomy. And so pretty interesting discussion as to the pros and cons of doing a canal wall up and down. But I think that's outside the scope of this debate. I'm going to focus on whether or not, again, surgery should be performed in a staged manner, in which you have a second stage that's planned ahead of time to look for residual or recurrent cholesteatoma. You'd also perform the OCR at that time, or you do everything in a single stage. So the advantages of a single stage, you have a single anesthetic period. I would disagree with Ash that I think that surgery would definitely cost more than performing a single MRI. So if you are able to do it in a single stage, I think that would lead to decreased healthcare costs, improved patient convenience. And if you're successful in your first stage of surgery, you can potentially avoid unnecessary surgery. And then in a double stage, again, it's an opportunity to catch residual recurrent disease. When you look at the data, single or double stage procedures have reduced recidivism rates, and I'll talk a little bit more about hearing outcomes later on in the presentation. I think ultimately the decision as to which technique you'd want to use is going to depend on multiple things. The staged technique, if you want to call it that, is a time-tested technique that a lot of people are comfortable doing, and so it's going to depend partially on the experience and the expertise of the surgeon who's taking care of that patient. Extent of disease, if it's very extensive cholesteatoma, you're probably going to lean towards wanting that second stage for surveillance. Patient's anatomy, if you have difficulty accessing all parts of the middle ear space, you may want to rely on that second stage to really ensure eradication of all disease. Patient comorbidities may sway you towards trying to do everything in one anesthetic period, hearing status of the patient. If you're unable to perform the OCR during that first stage, then the patient may be left with the maximal conductive hearing loss until they're able to get to that second stage. And then patient preference is also a concern. So it's a complicated decision. I think ultimately it comes down to this question: is there a randomized prospective controlled trial comparing a single stage for two-stage surgery? And the answer is no. And it probably doesn't make sense to even try to attempt one of these. Cholesteatoma is a very heterogeneous disease in terms of all the factors that I described in the previous slide. And the single stage and the dual stage methods of doing things are tools in our surgical toolkit. So why not just use them appropriately instead of saying that we should be doing more of one versus the other. So my answer ultimately to the debate question is maybe. It probably depends on the patient population you're treating. If that patient population has more severe cholesteatomas, or if they tend to be younger patients with more aggressive cholesteatomas, then I would totally stage more of the surgeries. It's a complex decision, and it doesn't make sense to be dogmatic about it. But to go back to the goals of the surgery and to look more closely at the first goal, to try to create a safe and dry ear. As I mentioned, one reason to do surgery is that it's actually a method of disease surveillance. It's kind of a costly and invasive method, but it is the most accurate way to see whether or not that surgery has succeeded and there's no residual or recurrent cholesteatoma. Physical examination is very poor in its ability to detect cholesteatoma. But what about imaging? And can imaging play a role in those cases that are kind of in between, not a clear-cut terrible cholesteatoma, but not a simple cholesteatoma that you'd feel fully comfortable doing a single stage for. If there's good imaging modalities to perform surveillance in that way, could we avoid second stage surgery? CT, in this paper that I looked at, they came down pretty much strongly not in favor of CT, saying that it's unreliable for differentiating cholesteatoma versus other types of tissue in the middle ear. But I think in certain cases, CT can be clinically applicable. You know, it definitely has more spatial resolution than an MRI. And depending on the shape of the abnormality that you see in the middle ear, you can use it appropriately. And then, as Ash mentioned, there's a lot of interest in these non-echoplanar diffusion-weighted imaging for detection of cholesteatoma. And again, Pete and Dr. Blevins did a nice meta-analysis on this. To briefly go through this is a systematic review of the literature on this topic. They reviewed and collected data from 10 studies, about 350 patients. These are all patients who were suspected of having cholesteatoma. They got pre-op scans of this particular type. They underwent surgery then to see whether or not the scan would be predictive. So in 230 patients who ended up having cholesteatoma in surgery, 204 were correctly identified by MRI. And the 30 that were not correctly identified, it was found that in most of those cases they had disease that was less than 3 millimeters in size. So there is a size limitation, weakness, if you will, to using MRI. And for the 108 patients without cholesteatoma, 100 were identified correctly. So they used pretty sophisticated statistical analyses and came up with these numbers, which I think are pretty good. But are they good enough to rely on scans versus surgery? I think that's up to the surgeon to decide. And again, to go over the goals, the second goal being hearing preservation. And it was thought actually that performing the reconstruction during the second stage of surgery would lead to improved hearing outcomes. And the rationale was that, again, they could confirm the absence of any disease, which would interfere with any hearing reconstruction. But it would also result in the sicculoplasty taking place in theoretically a mature, mucosalized, air-containing mastoid space, where the ossicular implant wouldn't be shifting around or moving as much. And so this is actually the same paper that Ash shows in one of his last slides. I thought it showed some interesting results. It looked at 83 patients with cholesteatoma. They all had OCR, either in the same surgery where they removed the cholesteatoma or a single stage, or in a staged manner. You see the numbers there, roughly equal for canal wall up and canal wall down, as well as either needing a PORP or a TORP. And I want to call to your attention in the middle of the table, you can see that in group 1 refers to that the group that had a single stage surgery. Group 2 had 2-stage surgery. And predictably, group 1 had a lot more PORPs than TORPs. I think that's consistent with the fact that they had less severe disease, which probably would have led to the surgeons choosing them to be in group 1 in the first place, so that's no surprise. Interestingly, the hearing results are comparable between the two groups. And then they further subdivided these groups to see if they can look for any meaningful statistical differences. You can see they divided them whether or not they had a canal wall down or a canal wall up, as well as what kind of prosthesis they used. And the things that came out statistically were in a canal wall down with the TORP. So these are presumably patients with the worst cholesteatoma. They have the most erosion of their ossicles. The patients who had staged procedures ended up with better hearing outcomes, which would kind of be inconsistent with the theory that I presented a few slides ago, that it should be better if you do it it is consistent with what I presented before, which is that the hearing results should be better in a staged manner. But interestingly, in the patients who had canal ups with PORPs, and so these would be the patients with the least amount of disease, presumably, the hearing results are actually better in group 1, going against the theory that I described before. And I want to take a step back and say this is all retrospective data, and so it's hard to make any conclusive determinations from this. Nevertheless, it's the data that's available to us at this time. So their conclusions from this paper were that decisions about when to perform OCR should be made on a case-by-case basis, depending on disease severity and resultant anatomy. When the OCR can be performed with tympanomastoidectomy and suspicion of residual cholesteatoma is low, they advocate single-stage surgery. And when you're doing a canal wall down tympanomastoidectomy and you're using a TORP, you should use a dual-stage surgery. And so I think after the research I did for this presentation, these are my kind of conclusions. MRI is pretty good, and I think that select patients with low risk for recurrent cholesteatoma can be reasonably followed with an MRI, which recent research again indicates that has pretty good sensitivity and specificity. And then the timing of hearing reconstruction is also something that should be individualized based on patient's extent of disease and resultant anatomy. And ultimately, the role for both the single and double stage surgeries exists.